Morning, everybody. Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from Emory University School of Medicine, Serious Communicable Diseases Program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Anna Yaffee. I'm an Associate Professor of Emergency Medicine and the Adult Care Work Group Lead for the National Emerging Special Pathogens Training and Education Center, and I'll be your host for today. Before we begin, please know that we will be recording this session and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in a collaborative and interactive manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. If there are any issues during the webinar, please send us an email or type it in the chat. If you would like to ask a question during the session, please use the Q&A feature. We will do our best to answer questions in real time and we'll discuss as many questions live as we are able to. If we do not get to all questions, we will post a recap addressing these topics on our website when the recording of this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC. Credit can be obtained for attendance upon completion of a survey at the end of this session. The presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. Here is today's agenda. As always, we will start with the Region 4 SITREP. This will be followed by our case and didactic presentations with a moderated Q&A to follow. And now it's my great honor to introduce our guests for today. Our case presenter for today's session is Dr. Srinivas Murthy, joining us today from Vancouver, British Columbia. Dr. Murthy is a clinical associate professor at the University of British Columbia, holding appointments in medicine and pediatrics. He is a practicing pediatric intensive care and infectious diseases physician, as well as a clinical epidemiologist, clinical trialist, and methodologist who has published extensively and broadly on emerging infections and global health. Unfortunately, Dr. Tim Uecke will not be able to present today. Our didactic presenter today will be Dr. Lindsey Gottlieb. Dr. Gottlieb is an assistant professor in the Division of Infectious Diseases here at Emory and practices adult infectious diseases in the inpatient and outpatient settings. She is the hospital epidemiologist at Emory University Hospital and the Emory University Orthopaedics and Spine Hospital. Her research has focused on transmission-based precautions, their implementation and efficacy, outbreak investigations, and reducing healthcare-associated infections. Lastly, I'd like to welcome back Ms. Jill Morgan, an emergency and critical care nurse with over 35 years of clinical experience. Ms. Morgan is the site manager for the Emory Biocontainment Unit at Emory University Hospital, known as the SCDU. She has tirelessly worked to validate the unit's processes and protocols, including safe donning and doffing of complex PPE ensembles, special pathogen waste, and recently created the cutting-edge healthcare test kitchen lab. She cared for all 5 of Emory's viral hemorrhagic fever patients, is a nationally recognized subject matter expert and leader in PPE with NETEC, and was appointed to the National Academy's Committee on Personal Protective Equipment in 2023. Welcome to you all. Now, to place this session in context, the Emory University Serious Communicable Diseases Program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channel, and listservs. Here is the current HHS Region 4 Special Pathogen SITREP.
Hi, I'm Gavin Harris with the Region 4 SITREP. First, to Nigeria, where the Lassa fever virus outbreak continues. As of the most recent official report released by the Nigeria Center for Disease Control and Prevention on the 9th of February, there have now been 1,913 suspect cases, of which 413 have been confirmed, and 80 have died since the beginning of this year, which equates to a case fatality rate of 19.4%. This is higher than the case fatality rate at this point in the year in 2024, which stood at 17.5%. Young people, ages 21 to 30, continue to be the most heavily affected demographic, And in positive news, no new healthcare worker infections have been reported in the past several weeks. However, the late presentation of cases to medical care continues to remain a challenge. Next, to Tanzania, where an outbreak of Marburg virus disease was declared on the 20th of January in the northwest Kagera region. Since that declaration, there have been 2 confirmed and 8 probable cases, all fatal. This marks a case fatality rate of 100%. Importantly, according to the WHO, all 281 known contacts of these patients have completed a 21-day quarantine and monitoring without evidence of additional transmission. On the 28th of January, a safe and dignified burial was performed for the last confirmed case. Given that one case was in that of a healthcare worker, the source still remains unknown, the high case fatality rate, and concerns about delayed detection and isolation, national and regional risk remain high, though international risk remains low. Teams continue to closely monitor the situation. And in encouraging news, the last patients in neighboring Uganda's Ebola Sudan virus outbreak have been discharged from hospital. On the 18th of February, the WHO reported that all 8 patients that remained hospitalized had been released following negative testing. Monitoring is still underway for over 200 contacts that are quarantined throughout the country, but at this time, no secondary transmission has been detected. This was Uganda's 6th Sudan virus outbreak, and as of now, there have been 9 confirmed cases and 1 death in that of a nurse. The case fatality rate of 11.1% is much lower than prior outbreaks and likely a result of the swift Ugandan and international response from WHO that included a rapid vaccine trial and deployment of therapeutic medical countermeasures. And lastly, to the subject of this month's Project Echo session, H5N1. In the United States, as of this week, there have been 68 total confirmed cases in 11 states, with additional cases pending confirmatory CDC testing. None have been reported in Region 4. Most infections have been occupation-related among workers exposed to infected poultry or cattle, and there's been no evidence of human-to-human transmission. On the 14th of February, the U.S. Department of Agriculture did give conditional approval to a new bird flu vaccine to be deployed in poultry. Healthcare workers are advised to remain vigilant and obtain early and appropriate testing of patients with consistent signs and symptoms of influenza. Rapid subtyping, especially for those critically ill, remains essential. And finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdu.emory.edu.
And now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge our base comfort level. So first, how confident do you feel about utilizing the processes of obtaining, identify, isolating, and informing as it pertains to encountering a person with a suspected case of highly pathogenic avian influenza, H5N1, from not at all confident to completely confident? And then our second question, how knowledgeable do you feel about the clinical management of a person with a suspected or confirmed case of AH5N1, from not at all knowledgeable to extremely knowledgeable? We'll give everyone a moment to answer these 2 questions. Okay, let's go ahead and cue our results. So thank you all for those that answered. We had several great answers. So for our first question, it looks like the majority of people feel slightly to somewhat confident to utilize the processes of identifying, isolating, and informing for patients with suspected H5N1. And then for our second question, it looks like the majority feel slightly knowledgeable about the clinical management of a suspected or confirmed case of AH5N1. So without further ado, thank you for the excellent answers, and let's begin. I'll first turn it over to Dr. Murthy for the case presentation.
Hi, thank you. So hello, everyone. My name is Srinivas Murthy. I'm calling in from Vancouver, Canada at the University of British Columbia, and I'm presenting a case to inform some of these conversations going forward about severe H5N1 disease in humans. For disclosures, I have no financial disclosures. I was asked to present a hypothetical case, but then, as folks probably know, this eventually turns out to be a real case. So it's all publicly available information that I am presenting. So let's get into it. Patient information. This is a previously healthy teenager with only comorbidities being some mild asthma that was untreated, obesity, and on no medications at home. She presents with a few-day history of malaise, fever, presents to an emergency room and discharged home with supportive care only. Over the next day or two, developed some vomiting and diarrhea, some conjunctivitis, and then progresses to have some difficulty breathing, for which she represents to a hospital. This is her initial chest x-ray on that second presentation. Obviously, there's some disease in the left lobe. Initially unremarkable electrolytes. Her creatinine was elevated. Our unit's 93. I think that's 1.05 in your units. Her CRP was elevated. Her white count was low, with a neutrophil count that was 0.5. She was then transferred, given her respiratory status, to our intensive care unit, at that time requiring non-invasive respiratory support. She had an NP swab done, which was positive for flu A, but negative for H1 and H3 biofire testing. And then based on that suspicion was subtyped and found to be H5N1. She was initiated on oseltamivir, which was what was available initially at the time. She worsened over the course of the next few hours and then subsequently required endotracheal intubation. After that, we had difficulty maintaining adequate oxygenation, and so she was electively cannulated onto veno-venous ECMO. This was her X-ray progression as she sort of progressed through the system. You see that lung disease here. Over the course of subsequent hours, it progresses, and then requiring endotracheal intubation, bilateral disease. And subsequently, ECMO cannulation. As folks know, during ECMO cannulation, there's often lung deflation, let's say. And so there's a lot of atelectasis here, as well as progressive disease. Anti-infectives were initiated at that point. Oseltamivir was continued. Baloxavir and amantadine were started to get combination antiviral therapy organized. We started a short course of antibacterials also with the suspicion of there being a superinfection. She did have negative bacterial cultures from her trachea and blood, and these were stopped after a few days. This is her virologic testing over the course of her initial admission. We had routine blood, NP, and tracheal aspirate testing to assess for viral loads as well as viral presence. The blood was positive initially, but then after the first test became indeterminate and negative after a week. The NP swabs were only done for the first few days. We then stopped doing it, and the risk of bleeding every single time we did one was there, and there was some oropharyngeal bleeding. And so we stopped doing that, and that remained positive. We used the tracheal aspirate as our primary marker for viral kinetics and showed that it continued to decline. And after about 2 weeks, it became undetectable per our influenza A cycle threshold. Oh, sorry, one more point to make. We did, during the course, check for markers of reduced susceptibility to antivirals that were being used, specifically the neuraminidase inhibitors, and we found no evidence of antiviral resistance during that course. So her total course, she had a VV ECMO run of approximately 2 weeks. She was invasively ventilated for 3 weeks. During this, she was also on dialysis, given her acute kidney injury that was present at the beginning, and she was present on dialysis either via continuous therapy or for intermittent hemodialysis for about a month. And their CNS status after we woke her up showed no evidence of neurologic disease. From an infection control perspective, throughout her course, we used airborne and droplet precautions. I use those in quotes because those are interpreted differently in different spots. But what we did specifically was had an N95, eye protection, gowns, and gloves in a negative pressure room with an anti-room. We did not know that she was H5N1 positive when we initially admitted her, but she happened to be in that room. And so that was convenient already. We continued these precautions until the virus was undetectable in her tracheal aspirate. And so once that was there, then we removed airborne and droplet precautions, and she was cared for with universal precautions. I will note that we continued the antivirals, all three of them, until we were confident that there was lower viral load. So until I think it was a 2.5-week course of all three of those antivirals. So key takeaways, and we can talk about these in some of the discussion points. Some of the clinical differences, both initial presentation and disease course between seasonal and avian influenza, how and whether to immunomodulate, the role of antivirals and what they did for her viral load and her overall disease course, some of the risk factors for severe disease, both in the general community and for healthcare workers, the viral kinetics, and how to initiate and what to do for staff protection. I think many of these are unknown, and it's great to have these conversations, and we'll hear more from our other presenters. I'll stop there. Thank you.
Thank you for that excellent case, Dr. Murthy. I'm going to turn it over to Dr. Gottlieb for the discussion.
Great, thank you. All right, so thanks again for having me today. And I'm going to be sharing some background information and current updates on highly pathogenic avian influenza A, with a focus on H5N1, acknowledging that this is not the only virus that gets this label, but today we are going to be focusing on H5N1. And as mentioned earlier, I have nothing to disclose. So I think it's helpful to start any talk on this topic with some anchoring in the background of what we've previously known about H5N1 to really understand why we're talking about it so much right now, acknowledging that this is not actually a new virus. So H5N1 is a subtype of influenza A virus that was first recognized in the mid-1990s in China. And it was recognized specifically in a particular type of domestic bird called the waterfowl. And it was initially associated with poultry or domesticated bird outbreaks with high mortality. And that's where the designation highly pathogenic avian influenza comes from. It has to do specifically with the pathogenicity in birds. And like other influenza A viruses, this specific subtype has evolved over time, which facilitated spread to other continents throughout the 1990s and early 2000s, but mostly in the early years was specifically confined to Asia. Human infections with H5N1 are also not new. So there have been sporadic cases of human infection dating back almost as early as when this was recognized in birds. A couple things to understand about this virus, this subtype, is that the receptors for it have been predominantly located in the lower respiratory tract rather than the upper respiratory tract, which may explain some of the low rates of human-to-human transmission that's previously been described. But there also are receptors in the conjunctiva, which will become relevant later in this talk. The majority of human cases historically have been in individuals who've had direct and close exposure to infected animals, mostly birds, though there have been a few cases of human-to-human transmission described in the past. These have all been individuals who've had prolonged and unprotected exposure to an infected individual, so typically household members who are caring for a sick individual. And notably, there have been not been any confirmed human-to-human cases of transmission in almost 20 years. Historically, these cases were presenting similar to how we think of a seasonal influenza as far as myalgias, fevers, and potentially pneumonia. However, notably, these historical cases have been more severe, with case fatality ratios in some regions being reported as high as exceeding 90%. So what's happened recently that's caused this to really jump to public recognition? So a new clade emerged in 2020 in wild birds. So as I mentioned initially, this was spreading in domesticated birds, but now we were starting to see it in wild birds. And that really facilitated global spread and ultimately detection throughout North America by the end of 2021. It's important to highlight that today there are now cases of H5N1 detected in all types of birds in all 50 states of the US. And then what really brought this to the public headlines was the detection of this virus in livestock in 2024, and particularly in dairy cattle, although it's not unique to dairy cattle, but this was really what brought it to public attention. So what are we seeing in dairy cattle? The clinical presentation is different than what we've seen in birds, which, as we described, has been really pathogenic and causes high rates of fatality. In dairy cattle, the virus has not been as fatal, and in some cows, the cows are completely asymptomatic, but it has affected the cow's ability to really do what they're supposed to be or bred to do as dairy cattle. So it can cause anorexia and decrease milk production. And due to the virus predominantly being located in the mammary glands of these cows, it's leading to high levels of virus in raw milk. Now, as I mentioned before, this is not isolated just to dairy cattle, and there have been other mammals associated with these outbreaks as well. You can see in the map on the right from the USDA that there has not been H5N1 detected in cows in all states the way that there have been in birds, but many states have been implicated in these outbreaks. So of course, what we in healthcare care the most about are human infections. And so jumping ahead to sort of what we've seen in our human infections in this contemporary outbreak, on the right, you can see the most updated map of human and confirmed infections. And you can see this is actually one number higher than even from Dr. Harris's SITREP, as this number was just updated, I believe, yesterday to reflect a new case in Wyoming. So we are now at 69 confirmed human cases since the start of the 2024 outbreak. The majority of these individuals who have tested positive have had either direct exposure to sick dairy cattle or poultry, but there have been cases with exposures to other animals, in particular backyard flocks or other wild birds. But notably, there have been a couple of cases without any clear links to animals, though no human-to-human transmission has been documented. What's been remarkable about these human infections compared to those previously described in prior outbreaks has been differences in the clinical presentation. So on the right is a table from a case series published in the end of 2024 of the first 45 cases in the United States of human infection during this outbreak. And the vast majority have been mild. Conjunctivitis has been common. So if you look at the top row of this table, both with exposures to poultry or dairy cattle, conjunctivitis was seen in more than 90% of individuals diagnosed during this outbreak. And while most cases have been mild, there have been severe cases, like we just heard about from Dr. Murthy, including one fatality in the United States thus far. So how are individuals getting infected if we do not believe that human-to-human transmission is a predominant route of transmission? Well, as we said, the majority of these individuals have had exposures to infected animals. And the CDC has made some really nice infographics to really show how individuals who care for these animals are getting exposed. So a lot of this is through direct contact or care for the animals, but there's also the possibility that with animals who have high burden of disease, that they can actually spread it, for instance, through flapping wings, through the air. And then for those caring for dairy cattle, there's a particular concern of eye exposure during the procurement of milk. So I want to jump ahead to testing and how we're detecting these cases. So it's important to understand that most commercially available influenza tests do not distinguish H5N1 from seasonal influenza. So for this reason, our public health authorities have had to take other approaches to try to identify H5N1 cases throughout the country. And they've been doing that through two different routes. The first is through monitoring and then targeted surveillance of individuals who are known to have been exposed to infected or sick animals. And through that, they've monitored almost 15,000 individuals, and then based on symptomatology, have tested about 800 of them. And the majority of the confirmed cases have been detected through this route, so through testing of individuals who've had known exposures. However, they want to make sure that we're not missing cases that may not have known animal exposures. And so our public health authorities have also been doing national surveillance where they've been subtyping a subset of all influenza A positive specimens from throughout the country. And through this, they've tested over 127,000 specimens and only identified 5 human cases. So again, this is not where the majority of cases have been identified, although a handful have been. Realizing that they're looking for a needle in a haystack, the CDC put out this health advisory alert about a month ago, asking for accelerated subtyping of influenza A in hospitalized patients. So a summary of the specific requests in this HAN were the following. So they recommended rapid subtyping of all influenza A positive specimens from hospitalized patients so that any strains that were then non-seasonal could be sent to public health labs for additional testing. They emphasized the importance of clinicians inquiring about animal or animal product exposure in any patients who are coming in with an influenza-like illness, and then utilizing enhanced isolation precautions, so airborne isolation with eye protection, gown, and gloves in the inpatient setting in any patient who has suspected or confirmed H5N1. So how are we actually accomplishing this? As I mentioned, most of our commercially available influenza panels are only going to tell us if a patient has flu A or flu B and nothing beyond that. Some of the commercially available extended respiratory viral panels are able to identify seasonal influenza A subtypes, so specifically H1 and H3. And for facilities that are performing that testing, then a non-subtypable flu A, so a patient who has a flu A result and is not identified as H1 or H3, may indicate H5 or another novel influenza A subtype. But the may here is important, as more often, this is just reflective of low levels of virus. Perhaps somebody has been sick for a while, and therefore the amount of virus they're shedding is just lower, and therefore it's not able to detect that seasonal flu target. There is H5 specific testing available through our public health labs as well as multiple commercial laboratories. I put a star next to our public health labs just because I know that many of our public health colleagues are just overwhelmed with the amount of tests that are being sent to them, and therefore the turnaround time on a lot of this testing is quite long. And with the commercial labs, there's differences between labs as far as what the specimen requirements are. So for instance, can they accept conjunctival swabs or only nasopharyngeal swabs, et cetera? So for anybody who is sending out commercial testing, it's important to understand what the testing requirements are for the commercial lab you're utilizing. Ultimately, from discussions with many colleagues throughout the country, the implementation of this health advisory recommendations has been variable. There's a lot of barriers to implementing this testing, including understanding who's going to bear the cost of additional testing, and then just figuring out sort of the workflows in our hospitals and for our laboratories to be doing this additional testing. A few notes about prevention. So first, what are we telling the general public? There's some common sense things here that can really, at this point, based on our understanding of the modes of transmission of this virus, keep our public safe. So number one is not drinking raw milk or eating raw animal products, as we know that there are high levels of virus in these products. Number two, avoiding exposure to sick or dead animals. And this may be more or less challenging depending on which part of the country you live in, and of course, where you're employed. But there's all sorts of scenarios in which we may come in contact with animals that we may not have thought twice about in the past, ranging from agricultural fairs, even going to petting farms at our zoos, and then a lot of instances of individuals having backyard flocks. And in particular, we need to really be wary if we're coming anywhere near animals that might be sick. A huge area of prevention here is in our agriculture industry. And while I'm not necessarily the expert to be talking about this in detail, you can see on the right an infographic from the CDC about how our farm workers can try and protect themselves when caring for animals. The amount of PPE required is quite laborious, especially difficult to wear in hot environments and not always available to our farm workers. And so there's a lot more work that can be done for farm worker protection here. What about in the healthcare setting? So there's a few common sense things we can be doing to try to prevent the transmission of any sort of respiratory virus. And really number one is masking any symptomatic patient who comes into our facilities. If there's any particular suspicion for H5N1, then the recommendation is to utilize an airborne isolation room if available, but at a minimum, a private room with the door closed. and then wearing the PPE that I described previously. A note about treatment. So big picture treatment recommendations are similar to seasonal influenza A, but I do want to highlight a couple of differences. So in anybody in whom you have suspicion for H5N1, you want to start empiric oseltamivir early. Unique to H5N1 would be that this recommendation is really for any patient in whom you have suspicion, regardless of risk factors or for progression to severe disease. There is particularly a recommendation for novel influenza A subtypes to consider combination therapy of oseltamivir with baloxavir in individuals who are immunocompromised or severely ill. And this is because of prior case reports of individuals with novel influenza A subtypes having potential resistance to oseltamivir, and then also extending the duration of treatment because of prolonged viral shedding that has been seen in these individuals. That being said, there's not any clinical evidence up to now showing difference in clinical outcomes with combination therapy, so this is more based on theoretical data. So some final sort of notes from the headlines that we're seeing in the past couple of weeks. So number one was this MMWR released, I believe, last week by the CDC, noting a seroprevalence study of about 150 veterinarians who care for bovine done in the beginning of 2024. And what they found was that of those 150 individuals, 3 of them had antibodies suggesting that they'd had H5 exposure in the recent past without having been known to care for infected cattle. And one of those individuals was actually in the Southeast region where there had not been any confirmed infections in cattle. So suggesting that there may be more widespread H5 in our animals than we even recognize. Importantly, none of those practitioners had had any symptoms of an influenza-like illness in the recent past. There's been a lot of reports of cats being infected with H5N1, and most of these have been in cases where cats are being fed raw pet food. So again, raw animal products are a particular concern. There have not been any reports that I'm aware of cat to human transmission, but we do need to be mindful again of our animals as a potential reservoir. Of course, the impact of this on our agriculture and farming industry has been significant, with a lot of headlines, particularly about impact on egg production and affecting egg availability as well as prices throughout the country. But one potential glimmer of hope that also was mentioned by Dr. Harris in his initial presentation is that just in the past week, there was conditional approval for a potential bird flu vaccine for poultry. And there's some controversy that surrounds vaccinating birds, and it impacts our ability to export birds. And so actually administering these to birds would be challenging, but maybe one tool in our toolbox moving forward. So some final takeaways. The risk of human-to-human transmission with H5N1 continues to remain low, and the evidence of this has not changed, but the impact on agriculture is significant. Our basic infection prevention principles are the same. We want to identify patients who are coming in with an influenza-like illness who've had either a high-risk animal exposure or who are found to have a non-subtypable influenza A result on testing that is able to perform subtyping. Any patient who's coming in with an influenza-like illness in our facilities should be given a mask early on, and if concerned for H5N1, isolated appropriately. And then it's important, if there is any suspicion, to inform your local infection prevention colleagues as well as public health authorities to be able to rapidly perform the additional testing and make sure the patient is isolated appropriately. Thank you.
Thank you, Dr. Gottlieb, for that excellent discussion. We will now open the forum for Q&A. So I'll invite all of our presenters and our discussants to come onto their video and participate in the Q&A. And reminder to our audience, if you have a question, please type it into the Q&A section that's on the bottom of your webinar screen, and we will attempt to get to all of your questions. So I've been monitoring the Q&A. It's been quite lively. And we also have some questions that were submitted at pre-registration. I would like to have the first question go to Dr. Murthy. There's been several questions about the antimicrobial management of the patient in your case, including the use of amantadine, the use of antibiotics, and there's another question about resistance to antiviral agents. I wonder if you can comment on the choices that was made in your case, as well as if you know of any resistance in the antimicrobial population for H5N1.
Sure. Yeah, and I didn't get into all of the specifics of the treatment strategies. Obviously, everyone knows this is a relatively evidence-free zone, and it would be great to have high-quality evidence to inform some of these decisions for both seasonal flu as well as for H5. Our choice to use three antivirals was mostly empiric, based on sort of thinking about making sure we try to reduce viral load as quickly as possible. And so the ones we had access to were oseltamivir, baloxavir, and amantadine. Although getting baloxavir itself was hard, we don't have readily available baloxavir in Canada. And we continue that. I saw a question about how long, and obviously the recommendations are less than what we did. And the recommendations are definitely not to continue to watch viral load and use that as your threshold for discontinuing. And so while we did something, I don't necessarily recommend that others do that. I think a few things were unique here. One, the severity of her illness. Two, we're sort of driving in an evidence-free zone, and so trying to do as best as we could and learn as much as possible by getting as many samples as possible, mostly driving those decisions. The antibacterials were only started empirically at the beginning because we weren't sure what was going on. As soon as cultures were negative from a microbiology perspective, we stopped those. Evidence of resistance was not present, and so we continued to monitor for resistance across viral specimens that were obtained, and there was no evidence that any inducible resistance was present across the antiviral agents we were using. And I think that's it, right?
Perfect. Thank you so much. My next question is for Jill. There's been several questions about PPE for providers caring for a suspected or confirmed case of H5N1, as well as isolation precautions and what to do about patient cohorting.
Yeah, thanks, Anna. So I guess many of us were hoping that we could put that COVID PPE away for a while, but it's not going to look like it. So if you have a suspected case, we really are talking about, as Dr. Gottlieb said, respiratory and eye protection and contact precautions. So a gown, face shield or goggles, and an N95 or equivalent respirator. Airborne isolation, if you have that available, and if you don't, then a private room with a closed door, and to be moved to airborne isolation when that's possible, especially if you're going to be doing any of the things that might increase the likelihood of spread around a room. And while cohorting in some places might be required, we hope that for the guidance right now would be that patients are placed in a private room, and we hope we don't get to the point where many of us would have to cohort, depending on the volume of patients. I don't know that anybody's got any great science-based information right now about H5N1 and cohorting, just because we've had so few cases within a hospital that are identified in a timely manner. So I think we'll have to wait for how safe that is, but I would avoid it at this point if you can. So yes, go back to a fit-tested N95, and good eye protection. You know, the estimates are that we touch our eyes, like touch our faces 20 or more times an hour. And that really is something that we need to concentrate on, both source control, protection, and good hand hygiene, to make sure that we're not inoculating ourselves later from touching things that are contaminated. Thanks, Anna.
Dr. Gottlieb?
Thanks. I want to also emphasize, since I didn't really get to say this in my presentation, that the recommendations for this level of isolation precautions is not necessarily based on any evidence that there is increased transmissibility of H5N1 compared to seasonal flu. In fact, if anything, right now it's the other direction, but really just based on the fact that we are still learning about this virus. We don't know how it'll evolve over time. And particularly given the prior severity of this illness, we would rather err on the side of caution. And I think that's really a lot of what's driven the current recommendations, as opposed to really rigorous science showing that this level of PPE will be necessary for the long term.
Jill, while I have you, there's also been a couple questions about waste and transport of laboratory specimens. Could you comment on that?
Sure. So first of all, I would say that if you are going to the trouble and the potential exposure of obtaining some of these specimens, we want to make sure that they're handled carefully, which means probably not using your tube system at your facility, depending on what your protocols are. We really recommend walking these things to the lab so you do not ever have to worry about re-obtaining a difficult to obtain specimen or one that was high risk. And then waste right now, these pathogens are not only H5N1, but our other influenzas are not regarded as being something that needs special handling with your waste. So this becomes your regulated medical waste stream as usual. And so if that changes, of course, we'll try to let people know. But for right now, all of this, it just becomes regular waste, which means you do need to be careful with it. We don't want to put any of our environmental services or laundry facilities at risk, but this does not need the category A special handling that we sometimes are on these echo sessions talking about with special pathogens.
Thank you, Jill. Dr. Gottlieb, there's been several epidemiologic questions about why on the map that both you and Dr. Harris showed, California is lighting up super heavily. Is there a reason for that? Is there more testing? Is there more exposure there? And then what is the risk for different types of exposures versus backyard flocks versus bird hunters versus larger agriculture?
Yeah, so I mean, I think some of this is definitely has to do with sort of where the majority of testing is occurring, but also once there is an outbreak in an area, we know that it's easier for the virus to then transmit between flocks or between herds in that region. So once it's taken hold in an area, that's obviously going to facilitate spread. There's sale of animals between farms, et cetera. Once an outbreak is recognized, that state does try to block more commercial sale of animals. But I think that's definitely what's allowed it to sort of spread in certain regions. And then also where certain regions that are more heavily focused in a certain industry are going to be more affected as well. Beyond that, I can't really speak to any other explanations.
Do you have any suggestions for healthcare facilities, both hospitals as well as outpatient clinics, for screening for certain exposures?
Yeah, I mean, we really are trying to get our clinicians to be screening about exposures, really to any sort of sick animals, but particularly dairy cattle or any type of bird, whether that's a commercial bird or a backyard bird. For any patient who's coming in with an influenza-like illness. So we're working on embedding those questions in our EMR every time that a respiratory viral panel is ordered to really remind our clinicians to be asking these questions, because they aren't really a routine part of questioning for individuals who are coming in without sort of a esoteric illness or presentation. But this is even more important in areas where you've got a lot of farm workers who have those potential exposures. I think where there's been the toughest decision points about what to do about are some of the other animal exposures. So for instance, domesticated cats. Many people are going to have exposures to domestic cats. The vast majority are not a concerning exposure. So do we really look for the needle in the haystack there? Or do we focus on the animals that we know have been sources of transmission in this outbreak?
Great, thank you. Dr. Murthy, there was some questions about kind of contact tracing for close contacts of the patient, as well as monitoring staff exposure, and if there was any need for post-exposure prophylaxis for anyone.
Yeah, it's a great question. And so there's all sorts of epidemiologic work was happening locally to try to figure out, one, the source, and then two, any specific contact tracing that had to occur. And so close contacts were isolated for a period of time, namely family members. For healthcare workers, there was no, luckily, all healthcare workers managed to have sort of enough risk prediction that they wore appropriate PPE during those initial periods of care so that there was no unexposed care happening. And so there was no specific follow-up or post-exposure prophylaxis given to any healthcare workers specifically. Yeah, and in terms of finding that local source for this individual patient, it still remains unclear as to where the epidemiologic link between this patient and the exposure to H5N1 initially occurred.
Thank you. Dr. Gottlieb, do you have any recommendations for pre-exposure prophylaxis for farm workers, whether that's vaccine or other PPE to help reduce exposure?
Yeah, unfortunately, we don't have any vaccines that are currently approved for novel influenza A viruses. So the recommendation number one is for everybody to continue to get their seasonal influenza vaccination, but that's really to reduce, the rare risk of co-infection and not having activity against the novel influenza A virus. So I think hopefully there will be more to come in the future on that topic. I'm not aware of any data otherwise on giving any sort of pre-exposure prophylaxis with medications, for instance, and most of the efforts thus far, from my understanding, have really been on trying to reduce exposure through environmental protections and PPE, which unfortunately has been a challenge.
Jill, this question is near and dear to my own heart. So Kimberly King has asked, as a frontline ER nurse, what are the signs and symptoms that will differentiate those patients from the high number of patients presenting with influenza-like illness right now?
It is so tough. So I think we probably are not going to be able to base this simply on symptoms. I think, as Dr. Murthy and Dr. Gottlieb have mentioned, these can be really difficult to figure out where somebody's exposure was, and then answering getting all the questions answered in triage of what all your potential exposures might be. It can be really difficult. So you might be able to ask in triage whether you've had any exposure to livestock or birds, but generally speaking, your best strategy is still going to be source control mask, hand hygiene, and then appropriate PPE for healthcare professionals. I absolutely agree. This is a challenge, and this was a challenge during COVID, and it's a challenge now. And I think making sure that we're not exposing people further, so putting source control mask on people is probably the best first step. But in many cases, as you've heard today, testing and identifying these and actually getting down through those pathways is not something that's going to happen very quickly. But Anna, I'd love to hear your perspective as an ER doc, what you think is if I'm missing anything that we might be able to do in the ER setting.
I think some conversations that we've been having in the emergency medicine community is like in areas where we are seeing maybe more cases or there's more agriculture or more risk of exposure, things like that, then maybe we ask more detailed exposure questions. In general, we always recommend that every emergency department and frontline healthcare facility use a universal symptom as well as travel and exposure screen. And so these types of exposures, tailoring it to your region, your area, and potential risk could be important.
Yes, so I think if I can just say before Dr. Gottlieb jumps in here, the identify, isolate, inform model is great. And then modifying it, as you said, Anna, to say, look, if I know I'm in a farming area, if I know I'm in a community that has a lot of backyard farms, or that people, maybe I'm right next to a zoo or something like that, where I know that I might have other exposures, you want to modify those questions. It doesn't always have to be somebody coming from a foreign country. You can modify those questions to address the risks that's going on in your community.
Yeah, absolutely. I was going to actually answer some of the other questions, but just to add to that, in speaking to some colleagues in areas that are more acutely sort of positioned in areas where they have a lot of farm workers, one thing they've brought up is where are these patients presenting? So even though we're talking a lot about subtyping our sickest patients to make sure we're not missing these cases, we may clinically treat them differently. The majority of these cases are actually presenting on the outpatient side. And so I know some clinics in areas that see a lot of outpatients who are working in this industry are really making sure that they're incorporating these kind of questions in those settings in particular. I saw there were a few questions in the chat about, or in the Q&A about sort of routes of transmission from animals. So just wanted to quickly address a couple of those items. So while there's high levels of virus in raw milk, my understanding is that the concern for transmission through the gastrointestinal tract is actually quite low, and that the acidic environment of our stomach should really handle that okay. So the concern there is more actually about aspiration of the raw milk rather than directly through the GI tract. So not a high risk, but still a risk that's there. And then as far as the meat, while in general there's a lot of reasons to not eat undercooked meat, this has really been focused in dairy cattle, not the cattle utilized for meat production. So for H5N1 specifically, there has not been a real concern with transmission through meat thus far.
And I put in the chat, or actually answered one of those questions in the Q&A. There was a study last year by APHIS that looked at meat. So I think that luckily we do have people looking, and we want to keep that going.
This is great. Thank you all. There's so many questions. Thank you all for kind of keeping this conversation going. And please, again, feel free to put any questions into the Q&A box at the bottom of the screen. Dr. Murthy, there was a question about why the patient what the risk factors for severe disease, basically. This was a young patient, but got a very severe illness. And what other types of heroic measures can be done for a patient with influenza with severe illness?
Yeah, I think the risk factors for severe disease is a tricky one, as we all know. I think it's hard to predict which patient will have very bad disease up front. This was a healthy teenager who just had some mild comorbidities, and so I wouldn't say she falls into any classical risk patterns for other viral infections and severe disease. We did do some immunologic workups and some genetic testing and so on, but nothing has really borne fruit there. In terms of heroic measures, one other thing that we did here, whether or not it's evidence-based or not, it's not evidence-based, was at day 5, I believe. We did a 3 days of plasma exchange, not necessarily for any specific indication, but for excessive inotrope requirements. And ongoing severe inflammation. We were debating how to best immunomodulate her and thought that that would be a strategy. Whether it worked or not is debatable and unclear, but eventually she did leave our ICU.
Thank you. Jill, I know we talked a little bit about the infection prevention precautions and PPE. There's some confusion about why an N95, why airborne precautions for H5N1 when maybe we wouldn't use that for standard influenza.
Yeah, and I think a part of this is, as Dr. Gottlieb has already mentioned, it might be something that we back off of later, but at this point, there's still an awful lot not known about the transmission of this particular strain of the flu. And I think that we should, at this point, be using great caution to start with and the ability to back off from that. I'd much rather take that position than say, oops, like many of us in healthcare have done, where, you come in on your 3rd shift and suddenly the patient's in isolation and you're like, why weren't we thinking about this 3 days ago? I don't want to ever have to go back and say, we wish we had you in an N95, 2 weeks ago when this patient first came in. So I think even if it's out of an abundance of caution, it's time we did that for healthcare workers. They deserve that protection. You shouldn't have to take any of this home. So if it turns out that we're wrong and you only need droplet, great. But we don't get the chance to undo that.
Thank you. Dr. Gottlieb, Dr. Lawler has left us a question in the chat about likely, based on math and what we know about the community attack rate, there's probably undetected symptomatic H5 infections across the US. How can we make conclusions about human-to-human transmission and clinical manifestations when we are looking at such a small subset of what is likely the true incidence?
Yeah, I think there's no question that we are still learning what we know and what we don't know, and that's some of what Jill just spoke to as far as why we are using a higher level of transmission-based precautions than what we currently know would dictate. I will say that some of the data is reflected in the case series that have been published so far for individuals who have had confirmed cases and not finding any chains of human transmission amongst those cases. So I think that is definitely reassuring given how many positive cases we have had and the ability to track their inner circles. But there's no way to definitively say that there has not been a single case of human-to-human transmission during this outbreak.
Great. Dr. Murthy, is there any concern for co-infection between seasonal influenza and H5N1? And if this happens, is there increased risk of mutations or other things that could create a worsened infection?
I'm not going to speak with any huge amounts of expertise on that one. I think theoretically, obviously, lots of things are possible. As we learn more about this virus and its human-specific immunology, we'll have to adapt and learn. And is there any specific concerns about that inducing resistance? I think all those things are theoretically possible, but is an unknown topic at this point.
And I think we have time for like one more question. Dr. Gottlieb, there's a question about wastewater testing. I wonder if you can comment about what's been going on in the country with that.
Yeah, so the wastewater testing is interesting. This is something that has been used by public health authorities for several months now to try to detect cases. I think one challenge that's occurred is that in regions where there are infected animals, much of their waste is actually being deposited in the wastewater. And so that doesn't necessarily reflect human cases in that area. And so differentiating animal cases versus human cases on wastewater detection has not been as useful as we might have hoped, but still can be used to just identify areas where there may be animal or human transmission.
I'll just plug here about wastewater transmission. There's a great podcast, Transmission Interrupted, that has a episode on wastewater transmission or wastewater testing for H5N1. So if that's something that you're interested in, definitely check it out. And there's a lot more information there. And so I think we're almost at the top of the hour. I think that will end our discussion for today. Thank you so much to our panelists and to our audience for your engagement, your excellent questions, and your conversation today. Before we close, I would like to just once again pose an interactive question to our audience after participating in this session. So how knowledgeable do you feel about the management of a suspected or confirmed case of H5N1? From not at all knowledgeable to extremely knowledgeable. We'll give you just a moment to answer. Okay, I think we can go ahead and show our answers. So it looks like our audience has moved from being slightly to somewhat knowledgeable to now being somewhat to very knowledgeable. So thank you for our excellent presenters for helping move the needle on that knowledge. Thank you again to everyone, and thank you to our technical team here at the SCDP ECHO, Yasmin Thornton, our Project ECHO coordinator and leader extraordinaire, our planning committee with Sharon Van Arsdale, Anish Mehta, and Allison Claybor. Thank you so much. For feedback and further information, including continuing education credits and the recording, please check the links here and our website. And I will just plug our next session, which is on March 27th on IPC for high consequence infectious diseases. Thank you so much, and we look forward to seeing you again soon.